A very good to all of you. On behalf of Society of Health Research and Innovation, I warmly welcome you to today's TCPD program. Today's topic is oxygen therapy in patient retrieval. The lecture will be delivered by Dr. Senitha Liyanage, Consultant Emergency Physician at Colombo South Teaching Hospital. Dr. Senitha Liyanage graduated with honors from Faculty of Medicine, Colombo, and brings over 18 years of experience in emergency medicine, anesthesia, and critical care. He obtained his MD in emergency medicine in 2016 as a member of the first batch of MD emergency medicine in Sri Lanka, followed by MRCEM UK. In addition, he holds postgraduate diplomas in critical care medicine, disaster management, along with a certificate of competency in anesthesia. He is currently completing a fellowship in palliative care in the UK in collaboration with St. Christopher's Hospice and the WHO. Dr. Liyanage is a well-recognized speaker at both national and international levels and accredited instructor in ALS, ELC, APLS, and WHO. It's my pleasure to welcome this eminent clinician to today's CPD Shri program. Over to you, sir.
Thank you very much for the kind introduction. As you all know, today we are going to talk on oxygen therapy in patient retrievals. In my lecture, I'll mainly focus on what is the oxygen, why we need oxygen, and then how to prescribe the oxygen, a new concept, and then we'll discuss the methods of oxygen delivery and then come to the patient retrievals. As the moderator described nicely, if you have any questions or queries, please put it in the chat box. We discuss at the end of the lecture. Let's see, regarding the oxygen, what is oxygen, when we are going to use it, and the types of respiratory failure, brief count on that, and then we go for the hypoxia management. We all use oxygen till we die. It's a colorless, odorless, tasteless inorganic gas. We are using oxygen as a therapy for last more than 240 years in the practice. We all use oxygen for oxidation of and ATP production. When you use the oxygen, a lot of clinical settings. Firstly, we use oxygen to treat the hypoxia, except the hysterotoxic hypoxia. We'll discuss those things that are part of my talk. And we are using oxygen for the inadequate oxygen delivery, that is a septic shock or any shock cases. And also we can use oxygen for carbon monoxide poisoning, huge list of oxygen use. And I like to highlight the oxygen is not the treatment for shortness of breath. The shortness of breath happens due to some other reason. So oxygen is the treatment for hypoxia. But still, we have to find out why we use oxygen, why the patient is shortness of breath, and we should rectify the cause rather than just giving oxygen to a patient with shortness of breath or hypoxia. So we'll discuss what are the types of respiratory failure. There are type 1 and type 2. And also some classification says that type 3 and type 4 as well. But type 3 and type 4 are all subsets of type 1 and type 2. So therefore, I'll stick to the type 1 and type 2 respiratory failure. And then we go for the signs and symptoms, bit of pathophysiology very briefly, and the bit of management. We know the type 1 respiratory failure is commonly used as hypoxia. The oxygen level is low with normal carbon dioxide levels, or even carbon dioxide levels can be low due to the increased respiratory rate. That means increased ventilation. Here, the definition is PaO2 is less than 60 millimeters per mercury, and primary issue is the failure of the oxygenation. The very common causes are pneumonia and ARDS, pulmonary edema, pulmonary embolism, any interstitial lung diseases, and high altitude. It is due to VQ mismatch, the shunting, and diffusion impairment. So therefore, we are managing by increasing FiO2 by giving oxygen, and also we can use increased mean airway pressure by applying CPAP, BiPAP, or any other invasive ventilation. And also don't forget to try to find out what is the underlying cause and manage that thing. Otherwise, we will keep on going oxygen therapy, but patient will just keep their parameters because of the oxygen, but we are not turn back the underlying pathology. And when you go type 2 respiratory failure, that means the carbon dioxide levels are rising. Often it is due to and associated with oxygen reduction as well. The key feature is the PCO2 carbon dioxide levels are more than 50, which is normally between 40 to 44 in blood gases. As I mentioned, the primary issue is failure of ventilation. When it comes to respiration, we have two main parts. One is oxygenation, second part is the ventilation. So oxygenation is a process that we take the ambient air into our lungs and improve the oxygen levels of the blood. But ventilation is the venting of. That means the whatever the produced carbon dioxide we are put from blood into the alveoli, that alveoli carbon dioxide comes into the atmosphere. That's the ventilation. And the mainly pathophysiology is it can be alveolar hypoventilation or increased carbon dioxide production. It can be due to high fever levels. It can be due to any carbon dioxide used in the laparoscopic surgeries. Those kinds of things also help to increase the carbon dioxide level or the carbon dioxide production in the body. Apart from that, COPD, CV asthma exacerbation, neuromuscular diseases where we don't have adequate minute ventilation or the tidal volume of the body, and CNS factors. A lot of factors can contribute to the type 2 respiratory failure. When you're managing, our main aim is to increase the minute ventilation. That means increasing the respiratory rate and the tidal volume. And also make sure we are going to improve the underlying cause. That is the most important thing. Always, whatever the respiratory failure, whatever the patient having hypoxia or inadequate breathing, always check what is the underlying cause, investigate for that, and then treat for the cause while we are maintaining the patient's parameters. The next, the signs and symptoms of the oxygen inadequacy. The commonest cause for sign is the agitation and the altered mental status. It is one of the commonest reasons we can find when the patients move from theaters or any other procedures to the ward. Patient can be agitated, no other symptom. So always look for the saturation. The commonest reason for agitation following the surgery can be the pain. It can be due to hypoxia, and also it can be due to full bladder. So always check the patient when it comes to the ward from any part of the sector of the hospital department, or can be patient maybe came from an ambulance. Just check why it is agitated. Always keep the pulse oximeter probe and check whether the patient is hypoxic and correct it. Very easy step, we can make the patient better. And also, we can check the cyanosis or low saturation as I mentioned previously, and always check for the work of breathing. What is the respiratory rate? Any increased work of breathing by use of accessory muscles, any recessions specifically in the pediatric patients, and also we can see the abdominal paradox, we can rocking boat effect. When the inspirating, the abdomen should always distended, but with each and every inspiration, if the abdomen goes into the body, in drawing, that means obstruction. And always, if you have a facility, please do the blood gases and see the problems with the oxygenation and the ventilation. In the management, there are two parts. One thing, the first most important is the resuscitation of the patient. The urgent resuscitation will use the oxygen. We have the airway control and ventilation management, the stabilize the circulation, and we can do the use the bronchodilators and the steroid if it is indicated. By those measures, we can buy some time till we do the necessary investigations and come to diagnosis and start the specific management. So oxygenation, we can use different methods of oxygen therapy. It can be nasal cannula, the Hudson or the normal face mask, venturi devices, non-rebreathing mask, and then we can go for the high flow oxygen nasal cannula and our NIV, CPAP or BiPAP or the invasive ventilation. Huge range we can do. We'll discuss those things that are part of my talk today. And always, as I mentioned, please have what can be the differential diagnosis and how we can narrow down the differential diagnosis by examination, history, past records, as well as investigations. Bit of physiology. We know the oxygen cascade, how ambient air oxygen comes into the cellular level. You can see here very small picture. There is a dramatic reduction of the oxygen level from the alveolar level into the from the air into the alveolar level, and also drastic drop here as well. We'll discuss specifically with the oxygen flask. So oxygen flux is the amount of oxygen which carries in the blood that affect of several reasons. One thing, the level of hemoglobin. Second is the saturation of the hemoglobin. Second thing is the cardiac output. So if you want to improve the oxygen carrying capacity of the blood, we have to check whether the patient's hemoglobin level is optimal. So no point of giving oxygen. The patient is anemic because though we are giving high amount of oxygen, the oxygen is completely saturating the hemoglobin, but the amount of carrying capacity is minimum because of no hemoglobin. So therefore, we have to optimize blood transfusion. And if the patient is having low cardiac output, no point of keep on giving the oxygen therapy. Oxygen therapy is good for initial way, but we have to improve the cardiac output. So this is our good old physiology. We have 4 types of hypoxias. The first is the hypoxic hypoxia. It can be to high altitude, where the partial pressure of oxygen is low in the ambient air, or it can be a problem with the lungs. It can be the lung volumes, it can be the poor mechanism or poor alveolar function. The second part is the low hemoglobin. So we use it as the anemic hypoxia. The first one is the hypoxic hypoxia. Then we come to the heart and the blood vessels. Any problem with the myocardial contraction, any problem with the obstruction, we have the circulatory hypoxia. And then at the tissue level, we are having histotoxic hypoxia, where the cells can't take oxygen from the blood. We call histotoxic hypoxia. Good oral physiology. What is the benefit of oxygen therapy? I have mentioned the hypoxic hypoxia. There's a significant benefit of the oxygen therapy to improve the patient condition. But in anemic hypoxia and stagnant or the obstructive hypoxia, there is some effect by giving oxygen. But in histotoxic hypoxia, where the cells can't intake oxygen, such as in cyanide poisoning, there is no point of giving oxygen to the patient because the patient can't use any more oxygen. So you can see there are 4 types of hypoxia. Only one type, the patient can use oxygen as the best way. Though it is one of the 4, but the most commonest hypoxia is hypoxic hypoxia. More than 80% of the patients are, if they come to the hospital to hypoxia, they're having hypoxic hypoxia. Therefore, majority of patients of hypoxia can get benefit by oxygen therapy. But you remember the other parts as well. Then we discuss the respiratory failures. We discuss the type of hypoxia. Then we are going to prescribe the oxygen. We all should know oxygen is another kind of medicine. So when you have the fever, we commonly give paracetamol. We never ask the nurses, just give some paracetamol. We always prescribe. Yes, the patient is having fever, the temperature more than 38, give 1 gram of paracetamol per adult person. And then check the temperature. The temperature is recurs in 6 hours' time, give another 2 tablets of paracetamol. Likewise, you are prescribing any medicine, you always prescribe it. So oxygen also should do the same. We should prescribe the oxygen. So we discuss what are indications in the type 1 and type 2 respiration and the hypoxias. What is the indication of giving oxygen? And we discuss what are our targets. What is the level of saturation we are going to achieve by oxygen therapy. And we discuss what is the duration, what are the forms, what are the devices or route of oxygen therapy, and oxygen is a drug. Each and every drug carries its own toxicity, side effects, adverse effects. We discuss that part as well. When it comes to the targets, our good old days, we had very, very high saturation targets, but everything now altered with the evidence base. So we know we are giving 100% oxygen with saturation goes to 100%, that gives rise to arterial constriction. So therefore, we don't give extra amount of oxygen more than the patient needs. So our target, if the patient is having hypercapnic respiratory failure, such as in COPD, our target is quite low. We keep saturation 88 to 92% of pulse oximeter reading. But any other patient group, we are giving 94 to 98% of saturation targets for all the patients. And then the oxygen toxicity. I mentioned the oxygen toxicity is common as other overdose of medicines. That may affect the two systems, the CVS and the RS. So on heart, the too much of oxygen in the blood can directly suppress the myocardial infarction, and also that can reduce the coronary artery diameter as well. And also, we all know with increased amount of oxygen, that increase the immune reaction or immune trauma by increasing the unstable ions. And also, the same way, the same immune problem, the same free radical formation can affect the lungs as well. And also, the patient with hypoxia with the hypercapnic failure, that reduces respiratory drive as well. So therefore, we always titrate the oxygen therapy to correct level. That means saturation target is 94 to 98 in all the patients except in hypercapnic respiratory failure, where we keep the target somewhere around 88 to 92. Then, how we can give the oxygen? What are the modes and the devices? When we go to oxygen devices, we have two groups. One is low flow devices, other is high flow devices. There's a small graph in the middle of the slides that shows the airflow during the inspiration. So you and me, we're taking a normal breath. The rate may be about 12 breaths per minute. That means our inspiration lasts roughly 1.6 seconds. That means we are taking 1 to 2 ratios of inspiration and expiration. We never measure it and take it, but normally that's our normal pattern. So inspiration is 1.6 seconds roughly. So therefore, you can see the green color graph. We are taking breath. Duration is 1.6 seconds from 0 level here and go up and come down. So our rate of breathing, the airflow, is vary from the pace of our inspiration. We are starting from the 0 level and it goes maybe up to 60 liters per minute at the maximum speed at the mid of our inspiration, and then inspiration wave cease to 0 before we start expiration. Our oxygen therapy, we all have flow meters, the regulators, that gives 15 liters flow rate of the maximum in the most of the regulators, not all. So if you give 15 liters, I have marked in the orange color box, only part of the inspiration is covered. Even we give 15 liters a rate with the 100% oxygen, only part of our inspiration is covered. And rest of the part, I breathe from the atmospheric oxygen. That is why if you use the face mask, normal Hudson face mask, if I give even 15 liters of oxygen, we can't achieve more than 40% of total percentage of oxygen because our oxygen or the air inflow rate is much, much higher than we are giving via the face mask. And it is not quite economical to give the very high rates of oxygen as well, because oxygen is a limited resource and oxygen is quite expensive. We all know how much oxygen is limited during our COVID time, because entire country had a state oxygen lacking to treat the demand. So therefore, here, the only key thing is normally we are giving maximum 15 liters via the face mask or the Hudson face mask. That can give only 40% of oxygen to the patient because our respiratory rate is with the airflow rate is a bit higher than we expected. But this green light, the green area is for normal patients. Then we come to the ill patients who are in shortness of breath. What is happening? The respiratory rate goes up. Rate may be 20. Previously, our inspiration is 1.6 seconds. Now it is reduced to 1 second. So during 1 second, it takes massive breath. Because of that, our inflow rates further goes up. So in patient, if we give Hudson face mask with 15 liters, we might not even get the 40%, that can drop to 35%. That is the reason more sicker the patient, more tachypneic the patient, our oxygen therapy should change accordingly. We'll see how we can match the demand or how we can win the situation. So therefore, we have a couple of devices we can choose accordingly. First, we'll go for the low flow devices. The low flow device, again, we have 3 parts: normal or minimum capacity, small capacity, and the large capacity. You can see the capacity. You can see here, the last one, the large capacity. There's a big amount of oxygen reservoir. So huge capacity. When the patient is breathing, the patient takes the breath from the oxygen which gathered in the face mask, and the rest of the oxygen or the air, what he needs, he takes from the oxygen reservoir, plus the oxygen comes from the tubes. So therefore, nearly 100% of the inspiratory air can be given by oxygen because that carries the reservoir. That's the most important part. Always the patient breathes from the reservoir. It never breathes from the atmospheric air. So therefore, in high capacity, the large capacity, we can go nearly theoretically 95% of FiO2 if we're using NRPM. And if you go for small capacity one, in the Hudson face mask, what happened? Patient breathe in and patient breathe out. And then the last part of the expiratory breath, which is trapped in the face mask. So therefore, if we don't give adequate rate of oxygen therapy, we will rebreathe that part as the first part going to the lungs. I think you got my point. So always when expiratory, the end of the expiratory air, which is trapped in the Hudson face mask, should flush away before the next breath. Otherwise, we do rebreathing, the small part of air. Anyway, rebreathing is there because we never get refresh the air in the mouth, pharynx, trachea, and the bronchial level, because always the expiratory level, expiratory gas remains stay there. That is why even we give 100% oxygen, we can't achieve 100% FiO2 at the alveolar level because of the mixing of gases. But how we can minimize the air trapping in the face mask or the Hudson face mask? If you want to connect the patient to Hudson face mask, always give minimum of 5 liters of oxygen flow to the Hudson face mask. I know the oxygen is limited. Some hospitals don't have oxygen supply from the pipelines or anything. So always we have to use another method. If you want to conceive some oxygen, and what is the other method is the nasal prongs. So nasal prongs, there are no capacity or minimum capacity. That means the oxygen capacity is only on the patient's nasal cavity. So whatever oxygen gives, that stores in the nasal cavity, and then patient breathe from that small capacity reservoir, and rest of the air patient is taking from the oxygen which comes from the tube, and the air comes from the atmosphere. So therefore, in this patient, we can give even 1 liter, 2 liter, 3 liter, or maximum is 4 liters, because even 1 liter comes that never trap the air in a face mask, so there's no rebreathing risk. And if you're giving only 1 liter, rest of the oxygen and patient take from the atmospheric air mixture. So therefore, if you give 1 liter, we can achieve 25% of FiO2, slight increase the FiO2 from normal 21%. And if you give 4 liters, you can go up to 37%, but not more than that. And the advantage of nasal prongs, it is easy to use. Patient can nicely talk, eat while doing the oxygen therapy, and it is comfortable, can use for prolonged use. But the problem is, it get the jet of air comes into the nasal cavity that increase the mucosal drying and crusting and epistaxis. But you can use very small dose. It's very effective, specifically in pediatric groups, because the jet of airflow will give increased pressure. It goes right up to the alveolar level. It can act as a small CPAP in little babies. But even adults, they are using nasal prongs. It is quite cost effective. And we come to the Hudson face mask. We are giving 5 to 6 liters per minute rate. We can go up to the 15 liters, and the FiO2 level I mentioned previously, that depend on the patient breathing rate and the breathing flow. That is why it's a variable performance device. When we come to the NRP, non-rebreathing mask, very effective because we can use roughly about 10 liters per minute flow just to keep the reservoir bag is insulated. When the patient is breathing, just check how the variation of the bag capacity. The respiratory reservoir is complete collapse at the end of the inspiration. That means the rate of oxygen we are giving is not adequate. We have to increase the oxygen rate. If the reservoir bag is full and it's not collapsing at all with the breathing, that means either two things. The patient is not taking adequate tidal volumes, or that can be due to increased oxygen rate. We are giving the supply of oxygen more than we need. So therefore, you can cut down the oxygen rate. So therefore, we can deliver consent up to nearly 100%, but it is not practically 100% because of the anyway that has some degree of mixing of the expiratory gases in the upper respiratory tract levels. But at the phase level, we can give 100% oxygen to the patient. And it's a one-way valve that minimizing the mixing of the inspiratory and expiratory valves. And always you should have tight seal. It's very cost effective if you want to give very high level of FiO2 to a person. Then we come to fixed performance devices. The fixed performance devices are the devices which give a very high flows. That means the entire 60 liters per minute flow rate is throughout the respiration. How we can achieve? We can use the Venturi mask. So you can see here on the down picture. So Venturi phenomenon or Bernoulli effect is where we are using the airflow through a narrowed opening that increases pressure jet that will entrap the ambient air. That is the key phenomenon we are using. Even you connected the 15 liters of oxygen to the green color funnel, that take high amount of air, atmospheric air, and that gives the 60% of FiO2. So always we are giving the fixed performance, the fixed amount of FiO2 because of this Venturi effect. So if you want the patient to connect to the 28% FiO2, we can use the white color funnel here, and we have to give the specific flow rate. If you want to give 40% of oxygen, connect the red color one, but we have to give 10 liters flow. So if you are using the green color one, we have to use 15 liters, then he will give 60% of FiO2. The patient is on 60% FiO2 with the 15 liters with the green color Venturi funnel, but don't reduce to 10 liters and tell now patient is on 40%. No, in that case, that's wrong because everything depends on the physiology. So if you want to have green one, 15 liters, that gives 60%. If you want to cut down, change the color and go for specific amount. Then other ones are the high flow nasal cannula. I'm not discussing that topic today. And we'll discuss later on about NIV, what is CPAP, what is BiPAP, how we are using those kind of things another day in the future. And we talk ventilators for the future. And this is the hyperbaric oxygen unit we are using in trichonaval base for the patients with decompression sickness. That's also another modality of oxygen therapy. Then, what are the specials on patient retrievals? How we get the oxygen? So oxygen, we have different ways. It is commercially produced in the 2 oxygen companies in the country, and also there are 28 PSA plants in different hospitals. That is how oxygen is get collected to our system. And there are domestic oxygen concentrators as well. We can get roughly 5 liters per minute or 10 liters per minute oxygen flow from domestic oxygen concentrators. But the purity is not 99% or 95%, but purity is less, but still it is effective. The patients that who needs about domestic oxygen therapy. And also we have pressurized cylinders and liquid oxygen cylinders. So you have seen in major hospitals all have this liquid oxygen storage, quite high capacity oxygen storage, which give the pipelines to the wards and the different units. When it comes to the oxygen cylinders, we all know oxygen is the gas which maintains our life. That also carries risk as well. It's a highly inflammable gas, always support the fire. And those cylinders stores oxygen under high pressure. We'll discuss those things in the future slides. So therefore, the safety features, we need the pressure release valve. And they are color coding and labeling to minimize the mismatch or the confusion with the other medical gases. And there's a valve protection cap. You can see here the cylinder with the valve protection cap. All the cylinders comes with this valve protection cap because we know when a cylinder fell down, there's a higher risk of damaging this valve or the nozzle. There are instances happen in the various hospitals in the various parts of the world when the cylinder fell down, that dislodged the nozzle, that create very tremendous release of the pressure, and that created some sort of missile kind of effect. That gas cylinder can fly for hundreds of meters and not at any place. So therefore, very common disasters can happen if we get the damage to the nozzles. To prevent that, all the cylinders comes with that valve cap. You can see the domestic LP gas that carries the valve cap, which is fixed to the cylinders. But what happened when cylinders come to our hospital? The people that were handling the oxygen cylinders, they remove this valve cap because it is quite practically difficult to connect the oxygen regulators with this cap. To make them our life easy, they remove the cap, but leaving the nozzle exposed to the environment. So always, if you have the cylinders, if possible, keep the valve cap. That is a very good safety measure. And the materials construct, commonly they are using steel ones, bit of heavy, and there are other methods like aluminium or the alloy, which is less bulky, less heavy. You can use it for easily with the transportation. And always, if you're using oxygen cylinders to patient transport, please make sure you're fixing the cylinder nicely to the trolley. Don't keep the oxygen cylinder on the trolley because that can roll and hit on the ground, lead to explosion, damage to the oxygen cylinder, as well as damage to the entire hospital if such event happen. So always mount the oxygen cylinder very securely. And also, if you are putting the oxygen cylinder into ambulance, always fix it securely to the ambulance rather than leaving it shaking and hit each other. When it comes to the medical air, the cylinder color coding, you can see here different oxygen gases are stored different color cylinders. Here we can have the medical oxygen storage with black color body and the white color shoulder. The commonest one comes as that way is the carbon dioxide. That comes as again black color body with the ash color or the gray color shoulder. So when the colors are wearing and tearing, sometimes very difficult to demarcate with oxygen and the carbon dioxide cylinders because when the white color one get dirt, that turn somewhere look like ash color. So it's our duty. If the color is not clearly visible and the body of the cylinder, more than 20% of the body color fade away, please label it as a need of repainting of the cylinder. That is the one way we can minimize the errors because we heard a very sad story in one hospital which happened due to unable to understand what is the oxygen cylinder versus the carbon dioxide. When you see that cylinder, very, very difficult to demarcate between the oxygen and carbon dioxide. So always check the color coding is perfectly done in the cylinder which you are using. If the color is fade, always double check what is the gas containing inside. How we can know? all the cylinders have this label that mention what is the gas, company name, the manufacturing things, everything. We hardly read these labels, but that also helps to demarcate if the color coding is disturbed. But my main advice is if the color coding is disturbed, better to send the cylinder back to have a proper color. When we come to the anesthesia machines, they are using this pin index system. Not all cylinders carries this pin index, but the specific cylinders which fits to the anesthesia machine having the pin index system, because there are a lot of gases we are using with the anesthesia machine. Here you can see the main pin in the center, and there are two pins which arrange one or two of these positions. If you take oxygen, here the pin position is 2 and 5. And if it's carbon dioxide, the pin position is 1 and 6, with wider. But if a person accidentally break one pin, that means one of the two bottom pins, that person can fix it tilting cylinder slightly to a different gas. So always make sure the pin index is correctly there in your anesthesia machine each and every day, because that can help to minimize the errors if a person fix the gas cylinder without having much knowledge. Then we come to gas cylinders. You have seen very varying of sizes of the cylinders. Yes, that's true, because we have gas cylinders donated by different countries, different people. So we are having huge range of gas cylinders, oxygen cylinders. We don't have much idea of their capacity. But I'll show you how we can minimize that errors. When we go to the gas cylinder sizes, the gas cylinder at our waist level is, we call F size cylinder. The F size cylinder that carries height is 34 inches and the capacity is 1,360 liters. That is F cylinder, F. And we use the smaller cylinder, the D cylinders, for transportation, because we had to use the patient from the ward to the ambulance. We use D cylinders, smaller size, easy to carry. But in the ambulance, we use F cylinder with higher capacity with increase in weight. So we are using F cylinders inside the ambulance, 2 internal cylinders minimally, and 1 external cylinders in the ambulance, that is D size. And we have jumbo cylinders as well, the larger one, but we don't use them for patient transport because it is not practical to carry huge weight of cylinders that can damage the ambulance, that increase the risk if any accident occurs. And next thing, how much oxygen we should take with us when you're transporting a patient. We never get the full cylinders always. Sometimes we can have 1/2 cylinders or 1 full cylinder. In that case, we should know how we can measure the cylinder remaining volume with the pressure meter. It is not that difficult. So when you fully loaded, you can see 2000. When you see the 2000 mark, everyone, not everyone, the most people, our health assistant, they says, sir, we have a cylinder with 2000 liters. No, this 2000 is PSI units. So 2000 is the pressure index we are using with a fully filled oxygen cylinder. That is the pressure level, but not the level of or liters of oxygen. If you connect A, B, C, or whatever the range, other than the jumbo cylinders, that shows the pressure reading up to 2000. That is the pressure level, not the volume inside. But we can calculate the amount of remaining oxygen in the cylinder if we know the cylinder capacity and if we know the current pressure level. So how we can do? The remaining oxygen level is full capacity. If we take that F cylinder, or if you take the E cylinder, the full capacity is 680 liters. But the pressure gauge, if it shows 1000, that means 50%. So the amount of remaining is 680 liters. Top level, the remaining pressure divided by the pressure of the total capacity, and that gives the amount of oxygen remaining in that cylinder. So if we use F cylinder, which is 1360, if the pressure is 800 of psi, the remaining amount is 1660 into 800 divided by 2000. Likewise, you can easily calculate what is the oxygen level remaining in that half-filled cylinder. Because we can't always ask, can you give me a full cylinder, because it is not practical. And what is the oxygen requirement? So oxygen requirement for a patient transfer, that depending on the duration of the transfer. So if you think a patient is going to transfer from Colombo South Teaching Hospital to NHSL Colombo, the drive is maybe with the ambulance roughly 15 to 20 minutes. But that take a lot of time to take the patient from the ward to the ambulance. Though it is ride is 20 minutes, again take time to take the patient from the ambulance to the NHSL ward or the ETU. Though the ride is 20 minutes, our complete duration of the travel can be goes up to 1 hour. So always think the duration of the transfer is not the duration of the travel. If we had the more lengthier travel in the ambulance, that two-part ratio can be shorter, but shorter the travel, that pre-hospital and post-hospital reach part is more lengthier. So always, when your travel duration, always calculate from the starting from the bed of the patient of the sending end to the bed of the patient of the receiving end. That is the travel duration, not just the travel time in the ambulance. And also the flow rate. The patient might having on the red color venturi device with the 10-liter flow rate, and that is the current oxygen requirement. So we know flow rate depending on the patient requirement. And sometimes the patient is on ventilator. Almost all modern ventilators are power driven, but there are very few ventilators we are using, old ones or some devices, those are oxygen driven. So they don't need any power supply, but that machine works because of the pressure of the oxygen. So therefore, some part of oxygen is used by the machine. So therefore, we should know what type of machines we are using or equipments we are using. So we should have the flow rate requirement for the patient as well as equipment. The equipment is oxygen consumption. And then the duration of the transfer in minutes we are using, as I mentioned previously, it is not the travel time only, but the total time of patient dispatching. And always we have safety factor. The safety factor is 2 times. If we calculating, my patient takes 40% of oxygen, that means 10 liters per minute via the red color venturi devices, and that rate is at the current level. I'm going to transfer the patient from Colombo South Teaching Hospital to National Hospital Colombo. My travel time is 20 minutes, but I'm expecting total duration of 40 minutes. Those 10 minutes from the ETU to the ambulance. In the ambulance, 20 minutes, but another 10 minutes from the ambulance to the NHS ETU. That means my travel time is 40 minutes. So 40 minutes into 10 liters, then I get the patient requirement of oxygen therapy, that particular transfer. But I multiply it by 2 times. Why is that? There can be any sort of delay or any sort of problems, increase the patient requirements during the emergencies. We are going in the roads, there can be traffic congestions, there can be any mechanical faults in the ambulance, and there can be any road traffic accidents. We don't know what we will face during our patient trans. So therefore, always measure the amount of oxygen level requirement and multiply by 2 and take that amount of oxygen. Sometimes any issues, we might have shortage of oxygen while traveling. If you're traveling long distance travels, in that case, always map what are the hospitals you can use that oxygen to for emergencies to refill. That's also another way, but don't keep it as a habit. Always take your own oxygen. And always keep the oxygen cylinders upright and secured nicely to minimize the damage to the cylinders, and always pack them without making knock each other, and always label the clearly, and always keep the regulators turned off when not in use, and transport safely. Don't go very high speed in the ambulances, go for a moderate level. And next thing is keep all the flammable materials away. Otherwise, there can be high chance of ignition. These are the flow meters we are commonly use. Different types, the splitters as well. Right? And so there are, I previously mentioned the things that we have considered are the patient transfers. So all the ventilators in the patient with the ventilator require additional oxygen more than we planned because patient condition can vary. We have to go for higher settings, higher pressure levels, high FiO2, always keep extra amount of oxygen. And as example I mentioned here, the patient of 100% oxygen consumed for 9 liters per minute, and then always calculate what is the total volume of oxygen we need, how many new cylinders we have, how many cylinders are half filled. Take as much as full filled cylinders, but you can't discard the half filled cylinders. You can take them if the amount is in the correct level. Why we always take the backup or the buffer amount I mentioned previously. So unpredictable patient demand and system losses due to leaks in the pipeline. There can be faults in the regulators and there can be increased wastage. So always to match the leaks, device failures, keep the devices completely checked before you travel, but take the ample oxygen. As I mentioned previously, the transport issues, the road traffic accidents, the weather constraints, sometimes the road may be closed, sometimes you can't use the route that you predicted. Therefore, always have the extra amount of oxygen or a backup plan. But my advice is don't go by the backup plan. Backup plan is the emergency method to take extra oxygen from another hospital, but it is not the routine practice. So that are the key things I'm going to discuss today. And any questions you can go and ask.
Thank you very much, sir, for that comprehensive yet concise lecture. We have many questions. We'll try to answer as many as time permits. In acute myocardial infarction, what is the SpO2 level for oxygen therapy, sir?
Yes, a very good question. So, our good old days, we learned in acute myocardial infarction, any patient with acute coronary syndrome, or any patient with head injury, we tend to use 100% target of 100% saturation in those days in earlier. Now, in the patients with myocardial infarction, and even in head injury patients, we never go for 100% saturation targets. That all depend on the BTS guideline 2016. They clearly mention, the studies have shown, if you give 100% oxygen for patients with acute myocardial infarction or any head injury patient, that increased level of saturation gives rise to constriction of the arterioles, constriction of the coronary arteries, that increase the artery resistance and decrease the arterial flow. Therefore, all the patients with acute myocardial infarction, the current guidelines since 2016, we are practicing the saturation target of 94 to 98%.
Thank you, sir. So, what are the preoperative hemoglobin levels for a patient with ischemic heart disease, chronic kidney disease, and for a patient without any comorbidities?
Yes, the level of pre-op hemoglobin levels that depend on couple of factors. One thing, the baseline function of the patient. Second thing, what is the expected blood loss during the surgery? So basically, if the patient is fit and young person and there's no blood loss during the surgery, we are happy if the hemoglobin is more than 10. And the patients who are having kidney diseases, if you're not going for surgery, we are keeping the hemoglobin level somewhere around 8 or above. The patient is on erythropoietin injections. But if that person needs the surgery, that depends what the blood loss. Basically, we are keeping at 8 grams of deciliter hemoglobin level, and we are keeping the extra amount of blood to give if needed. But it's not advised to go for always the target at 10 or above hemoglobin level, but we keep the buffer blood with us.
Thank you, sir. If possible, can you briefly explain the different uses of CPAP and BiPAP? There are a couple of questions, like many people have asked that.
Very lengthy part. I promise we'll do another session.
All right, sir.
In the future of how to use NIV, what are the differences, pathophysiologies, and uses of BiPAP and CPAP.
Thank you, sir. Yeah. Sir, in an OPD setting, during the management of mild asthma or COPD exacerbations requiring nebulization, if pulse oximetry is unavailable and the patient's oxygen saturation is unknown, should supplemental oxygen be withheld?
Yes, another good question, because we are using a lot of health settings. Some patients from hospitals are not that fulfilling about the needs. So they don't have pulse oximeter. So therefore, what we advise is, for a short time, even a COPD patient, no harm of nebulize with using oxygen. So guideline says, if the patient is known to have hypercapnic respiratory failure and saturation within the range, then you can nebulize without oxygen by nebulization machine. But in our setup, if you don't have the blood gases to assess the hypercapnic respiratory failure, and if you don't have saturation probes also, therefore no harm of nebulizing for a short duration with oxygen-driven nebulization. And also when you nebulize with patients, so we have filled the canister with a total of 4 to 5 ml of solution. That means we are putting 1 ml of salbutamol or 1 ml of ipratropium bromide. That means total volume is 2. And then we are adding normal saline, another 2 or 3 to make the entire volume 4 to 5 ml. And that should connect to the oxygen. Oxygen flow rate of the nebulization should be 5 to 6 liters per minute. If don't put lesser amount, don't put too much of oxygen, keep it around 5 liters per minute, then you give the optimum nebulization. Even the patient is COPD, no harm, you can do that level of nebulization because we don't use oxygen for long time.
Thank you, sir. Sir, should we use oxygen for head injury patients?
Yes, for head injury patients, all any emergency, the saturation level is less than 85. You can use non-rebreathing mask. Any patient who are having head injury, use oxygen if the saturation is less than 94%. It's a head injury patient, the saturation is around 95, 96. No need to give additional oxygen. So our target is 94 to 98 in head injury patients.
Thank you, sir. Sir, is it okay to give oxygen via NRPM for a longer period of time?
Yes. Yeah, we can actually for NRPM we are using as a bridging therapy. Bridging therapy means we are initiating treatment. It may be the underlying pneumonia. We are starting just physiotherapy. We are starting antibiotics. We are starting steroid and positioning of the patient. All the measures, and we are connected to the NRPM. We can continue for 1 to 2 days of NRPM. And then, if the patient is not improving, if the patient is having a very high respiratory rate, if the patient shows any respiratory failure features, in that case, we have to go and start NIV or invasive ventilation.
Okay, thank you, sir. One last question. What is the recommended SpO2 for term and preterm neonates in order to prevent retinopathy of prematurity, sir?
Right. That is bit of out of my scope because those are belonging to the neonatologists, right? That is, I think, we should go with the neonatology guideline.
Yeah, thank you very much, sir. So, with that, we have come to the end of today's CPD program. I would like to thank our speaker today, Dr. Senitha Liyanage, consultant emergency physician at Colombo South Teaching Hospital, for delivering such a valuable and clinically relevant presentation. And thank you, sir, for contributing to the professional growth of our members. And we sincerely hope that you will continue to contribute to the Shri program in the future as well. And also, I would like to thank all our participants. And please remember to fill the feedback form as well as the post-assessment questions in order to obtain your CPD certificate. The link has appeared in the chat box. And also, upon completion of the feedback, you will receive the certificate within the next 1 week. And with that, we conclude today's CPD session and wish you all a pleasant day ahead. Thank you.